The topic for good morning, everyone. The topic for today's class is the Phacodynamics. The purpose of this class is to make fellows understand how Phaco machine works and what is the significance of the Phaco machine. So I will be covering these topics: introduction, instrumentation, and components. Then the main part, which is the Phacodynamics, and the a few basic terms. So the modern era of cataract surgery began in 1967 when the Charles Kelman invented the phacoemulsification. So you will be surprised to know that the first surgery took around 76 minutes, but the procedure gained popularity in 1990. So there is a huge gap between the 1967 and 1990. So the phacoemulsification has two basic elements. First is the ultrasound energy, which will be helping to emulsification of the lens, and then the fluidic circuit, which will maintain the anterior chamber and prevent the potential heat buildup and remove the pieces from after the phacoemulsification. So this was the first machine, which was known as the Cavitron, which is made by Alcon. So this is the first machine. And here are some eponyms which you need to know what are the names associated with the Kalman. First is the Kalman forceps Phacotip, and Kalman is known as Charles Kalman, also known as father of phacoemulsification. And there is an IOL which is Kalman multiplex IOL. And there is a technique of ICC which is also called cryo extraction. So and next is the Kalman also introduced the retinal cryopexy for the retinal detachment. So I would like to ask fellows that do anyone know that the father of Indian phacoemulsification? Who is the father of Indian phacoemulsification? Any fellows? Okay. So the father of Indian phacoemulsification is K.K. R. Mehta. So Dr. K.K. R. Mehta is also known as the father of Indian phacoemulsification. Then the instrumentation. First is the irrigation bottle height, then the console, and here is the foot pedal, which is the most important part. Then the phaco pro, phaco probe and phaco needle, and the sleeve. And one more thing is tubings. Tubings are very important. So we will talk about each part one by one. So first is the console. So this is the basic Otley phaco machine, which is very commonly used in our setup. So the console is a computer which controls the setting for the various parameters. So it has various buttons, and sometimes it is also a touch screen with which you can change your modes. And newer machines also have a multimodal panel which includes the modes like cautery, anterior vitrectomy, and diathermy. Multiple settings of all variables and grade of the cataract are fed and changed during the phacoemulsification surgery. So you can change the modes with the foot pedal also. So second part is phaco handpiece. So phaco handpiece and the irrigation and aspiration handpiece. So this is a basic phaco handpiece. So ultrasound energy is produced to and fro oscillation of the phacotip generated by the inverse piezoelectric effect. So uh, can any fellow tell me about the what is piezoelectric effect? Any fellow? Okay. So piezoelectric effect is when the mechanical energy is converted into the electric energy. This is piezoelectric effect. And when the electric energy is converted into the mechanical energy, it is called inverse piezoelectric effect. Okay. So there are some substances which shows this property. One example is quartz and the lead zirconate titanate and many more. So whenever these crystals oscillates, so there is also production of the torsional and elliptical motion of the phacotip depending on the type of tip we are using, which helps in the breakdown of the nucleus. So basically, the phacotip is a combination of the jackhammer, vacuum, and the irrigation water jet. So it emulsify and aspirate the nucleus while keeping the tip cool and maintain the anterior chamber. So this is a basic internal structure of the phaco tip. So I have told you earlier that it work on the basis of the piezoelectricity. ठीक है, piezoelectricity पे काम करती है. So whenever the electricity is passed through the power cord, electric cord, it is directly transmitted at the piezoelectric crystals, ceramic crystals. Here I'm drawing in a diagram. Here we have the ceramic elements, and whenever the electricity passes here, so it vibrates. Its vibration is directly transmitted at the phaco tip with the help of the connecting body. So this is how it works. And the phaco tip also has a aspiration line. So the whatever the nuclear pieces are broken down here, it is directly aspirated through via the aspiration line. And to maintain the anterior chamber, it also has an irrigation line, which is here. So you need to understand the basic structure so that you can operate it very well. Now the important aspect, I think it is very important aspect fellows need to know. So Phacotip, Phacotip. So Phacotip has many angulations which are available: 0 degree, 15 degree, 13 degree, 30 degree, 45 and 60 degree. So it is although it is chosen as per the surgeon's preference, but the most commonly used is 30 degree. So the basic principle is the more the angulation and more is the cutting power. So there are some modifications of the tip which should be known, and what is the significance of each tip you need to know. So first is the standard tip. Whenever I am talking about the standard tip, you need to keep in mind that standard means the 19 gauge standard needle, which has an internal diameter of 0.9 millimeter. This is the standard size of the phaco tip. Then second is the micro tip. As the name itself is saying that it's the micro tip, and the bore size of the micro tip is the internal size of the 0.6 millimeter, not the 0.9 millimeter, and it is the 21 gauge micro needle. तो इसका significance क्या होता है? So what is the advantages? So small size, it means we can work by the small incision also, precise cutting and surge protection. Surge protection, we will talk about this in a later slides, how it prevent the surge. Then the Kalman 45 degree. Kalman 45 degree means there is a bent, 45-degree bent at the distal end of the uh, phaco tip. So it is very helpful in hard cataract. So it also adds the elliptical motion and adds total cavitation at the tip. So what is the significance of down curve? You need to know. Anyone can ask in any exam. Okay, so the down curve will help to decrease the stress on the wound. How? So whenever you have a straight needle, you need to angulate it more to reach the central core of the nucleus. Whenever there is a down curve, you need not bend your phaco needle to reach the core of the nucleus. So this is how it decreasing the stress on the wound. Then the flared tip. So the flared tip, you can say it is a modification of the micro tip and standard tip. As I told you in the previous slide, this part is it will act as a micro tip, and this part will act as a standard tip. So the diameter is according to that. So the micro tip has diameter of 0.6 millimeter, and it is flared from the distal end, and it has a 0.9 millimeter diameter. So what is the significance? So the I have told you in a previous slide that the microtip has a action of it will prevent the surge, so there is a less surge. And standard tip, when it is when it has a wide diameter from the distal end, it will it has a good hold. So it has a better hold because it has a distal and more diameter. So the small proximal diameter will lead to more fluid resistance and more prevention of surge. Big distal diameter will lead to more nuclear fragment hold. Second, next, Kalman 45-degree balance tip. So I told you in a previous slide that Kalman has a bend and balance tip has a second bend. So as you can see, there are two bends in the hair. One is the hair and second is the hair. And what is the significance? It optimizes the energy delivery and it improves the safety by reducing the thermal strain on the eye and it enhances the efficiency for smoother and faster procedure. Next special tip is the aspiration bypass tip. As the name itself indicating that aspiration bypass tip. So it has a small hole of around 0.18 diameter. You can see here. So why it is made? Why it is made here? So whenever there is a occlusion at the phaco tip, like suppose this is the nuclear piece I'm making here. Okay. So there is a continuous flow beneath the sleeve from here. Continuous flow of fluid from here to here. So whenever the occlusion breaks, so it will not lead to the surge. This is how the surge is prevented with the help of aspiration bypass tip. So it leads to continuous outflow throughout the emulsification during occlusion. Its key advantages: it cool down the phaco reduce thermal injury to the anterior chamber and incision, and less chances of surge. So there is one more tip. There is one more tip which is called Barrett's microflow tip. So this tip has a special grooves, external grooves beneath the sleeve. Here I'm making with the help of pen. So what it does, it what it does that whenever the sleeve is compressed against the wound, whenever the sleeve is compressed against the wound, so the fluid flow is not hampered and it has a less surge due to the small diameter. So this tip act actually like a flared tip. Can you see the internal structure I'm making with the help of pen? It is like a flared tip. Its internal structure is like a flared tip. So it will act like a flared tip. Next is the diaphragm tip. So in a diaphragm tip, there is a small constriction at the lumen. The purpose of this tip is same, to prevent the surge and to provide the resistance to the fluid flow during aspiration. So it prevents the turbulence at the high flow rate and causes less surge. Now the most important aspect is the Phaco foot pedal. So this is the foot pedal. So it consists of basically, it depends at which mode you are operating. In a Phaco mode, so you have three modes through three positions. First is the irrigation only, then is the irrigation and aspiration, and third is the irrigation, aspiration, and ultrasound energy. And if you are operating it in a irrigation and aspiration mode, you have irrigation and aspiration only. So whenever you press the foot pedal, whenever you press the foot pedal, you will have a tactile feedback whenever you press it. Okay, where the pedal position changes, and console with the change of the mode, you will have a sounds also, which is also called the auditory feedback. So I would advise our fellows that if they want to learn Phaco or if they want to start the Phaco, then they have to work on these feedback in a any small bowl or any kidney tray, uh, to learn the tactile feedback and auditory feedback, and then switch over to the patient. So before attempting phaco, person has to train himself or herself in both the feedback, and later on, once they have mastered the tactile and auditory feedback approximately around 10 to 15 times, then you need to repeat these under the microscope and develop visual feedback. These are the steps you will learn phaco. So after tactile and auditory feedback, just move on to the visual feedback under the microscope. Then the sidekick function and heel button. So you can move your foot pedal left and right as per your ease and needs. And important sidekick, one of the important function is this reflex. So a few machines also have pulse on off button, bottle height adjustment and multimodal panel, which is also controlled by the foot pedal itself. So the function of sidekick or heel button can be changed as per the surgeon's ease with the help of console. So the heel button function is to, in this Otley machine, the heel button has a function of on off continuous infusion mode and reflux mode. So the main part, which is the phacodynamics. So most important aspect is the ultrasound power. So with the help of piezoelectric crystals, ultrasonic vibration is produced at around 25,000 to 60,000 hertz or 25 to 60 kilohertz per second. So there are 2 to 6 piezoelectric crystals which are activated with the help of electricity, electric code. So you need to understand what is power. Power is nothing but just a linear stroke length of the phaco which is approximately around 100 microns. So sometimes some fellows misunderstood it with the frequency. In the phaco power, frequency remain unchanged, but the stroke length changes. So it is basically the movement of the, suppose in the first diagram, suppose the phaco needle moves from here to here completely. That means 100 microns or the 100%. So this is the 100 or 100 ultrasound power. The movement decides the ultrasound power. So stroke length is the travel length or the how far the phacotip moves back and forth. So if it moves half, that means 50%. So it means you have 50% ultrasound power. Sometimes जब हम ओटी में बोलते हैं कि 30 पावर कर दो, 20 पावर कर दो, या फिर 60 पावर कर दो, इसका मतलब ये होता है कि जो स्ट्रोक लेंथ है वो हम कम कर रहे हैं. ठीक है. Power is varied by stroke length. Power can be so the power can be longitudinal, torsional, and elliptical. So what is the mechanism of phacoemulsification? First is the jackhammer effect. So this is actually the jackhammer, which works on the same principle. So it is the mechanical bombarding action of the tip. Second is the cavitation phenomena or the implosion. So it is the high velocity of the tip moving backwards, which causes surrounding fluid to fall into the cavity and causes disintegration of the nuclear material. Third is the acoustic shock wave of the fluid. Forward movement of the tip causes disintegration of the softer lens material. So, as I also told previously that newer machines have transverse and elliptical movement also. Sometimes remember this point. Sometimes the more power causes chattering, wound burn, and contracture or damage to the endothelium. So, the torsional and elliptical phacoemulsification reduce the chattering, reduce the total phaco energy, and torsional movement is amplified with the use of curved phaco tip. And the elliptical cutting leads to nucleus emulsification. It enhances the nucleus emulsification. Now the phaco power modulation. What does it mean? Phaco power modulation, and why are we doing this? So we just want to decrease the total energy delivered into the eye because it has many side effects like development of heat energy. wound burn or the damage to endothelium. So we want to reduce the total phaco power delivered. So its purpose is to reduce the total energy, reduce the chattering, and improves the followability. So it grossly involves the pulse and burst mode. So what is the pulse mode? You need to understand this. So the each pulse of the energy here, each pulse of the energy is followed by the equal rest interval, like this. Suppose this is the energy and this is the rest interval. So this is the one cycle. Okay, again energy followed by the rest interval. So in this case, the frequency of the pulses is fixed and the energy is variable. So the frequency is fixed and energy is variable. You have to understand that. Okay, so most of the machines have 0 to 12 pulses per second. It almost halves the total power use. Few machines also have hundreds and thousands of the pulses. So it is also called as hyperpulse mode. Next is the burst mode. So it is very useful for chopping in hard cataract. So here the energy is fixed, as you can see. Energy is fixed and the frequency is variable. How it is varying? Frequency is variable with respect to the foot pedal depression. So how it works? So when the foot pedal depressed fully for a long time, the power delivered is continuous. So suppose like in this diagram, suppose it is coming at 10 millisecond. After that, if you are keeping your foot at the foot pedal and depress it, so it will keep on reducing. The interval keep on reducing. 9, 8, 7, 6 and एक टाइम आएगा जब ये continuous power deliver होना start हो जाएगी. So इसमें आपको जो याद रखना है वो energy is fixed and frequency is variable. Frequency is changing. Next term is duty cycle, which you need to understand. So it is the total on time upon total on time plus off time in a single cycle. So for example, you have a so suppose you have a this single cycle from here to here. This is a single cycle up to here, up till here. So जो भी on time है, so that will be your duty cycle. Suppose in this case it is this is the on time, which is so it will lead to 50% duty cycle. So in this case this is the on time 75%, so it is the 75% duty cycle. So basically it is just a on time in a single cycle. So अब अल्ट्रासाउंड एनर्जी हो गया, उसके बाद अब फ्लूइडिक्स की बात करते हैं. तो अब अगर हमने न्यूक्लियर स्पीसीज को ब्रेक कर दिया तो उसके बाद एंटीरियर चेंबर मेंटेन होना चाहिए, और उसके बाद जो न्यूक्लियर पीसेस एंटीरियर चेंबर में पड़े हुए हैं उनको एस्पिरेट भी करना है. ठीक है. सो it is the integrated functions performed by the infusion and aspiration system. So this is the path of the fluid which you need to know. You must know actually. Okay. So this is how the fluid wave travels first from the irrigation bottle, then irrigation line, then the phaco tubing. Then after that it enter into the anterior chamber, and after that it is aspirated through the aspiration line and eventually at the pump and lastly into the cassette. So the basic fluidics of all the machines is almost same. So first the infusion bottle. So this is the infusion bottle of balanced salt solution. Sometimes people ask in a MCQ, or sometimes they ask in a Viva that what is the composition of the BSS. You can remember this: sodium chloride, potassium chloride, calcium chloride, magnesium chloride, sodium acetate, and sodium citrate. So these tubings from the bottle is run through the pinch valve, which is controlled by the foot pedal. foot pedal. Whenever you press the position 1, so the pinch valve is activated and it will lead to flow of fluid. So it is gravity fed system basically, which is grossly 60 centimeter of bottle height will lead to approximately 44 millimeter of IOP in the eye. So the irrigation cools the phaco during the emulsification. Excessive, sometimes you have side effect also of using the excessive bottle height, which you need to note down. So first is the zonular stress, second is the patient discomfort, AC fluctuation, and meiosis and repeated iris prolapse. So it should be adequately raised. Then the aspiration system. So the aspiration system, the flow rate attracts the nucleus or cortex into the phacotip, and the vacuum determines the holdability. So remember this. Vacuum holdability is a function of the vacuum. So vacuum is measured by the pressure transducer connected with the aspiration tube. So we will talk about the basic pumps we have available. So first is the aspiration pump, and the second is the flow-based pump. A second is the Venturi-based pump. So peristaltic pump, it is called flow-based. Why? It is called flow-based because peristaltic pump directly controls the aspiration flow, aspiration flow rate. So that is why it is called flow-based. And second is the Venturi. It directly controls the vacuum. So it is also called a vacuum-based pump. So in a peristaltic pump, the movement of the fluid or the water uh, occurs in a small pockets. So it is called peristaltic, like peristaltic movement in the small intestine. How it happens? Like this. So food moves with the help of peristaltic movement itself. है ना? So here the water moves in a small packets, like here with the movement of the rollers. So whenever the roller moves, the water movement occurs, and this will lead to aspiration, development of aspiration flow. So this is how it works. And the vacuum based pump. So there is a can any fellow tell me about the what is Venturi principle? Any fellow? So, so Venturi principle is when a compressed gas travels through any closed chamber, so it will lead to the development of vacuum, negative pressure in the closed chamber, which is directly connected to it. And in the phacoemulsification part, it is directly this chamber is directly connected with the help of phaco probe. So this is how it works. So the vacuum is directly transmitted at the phaco probe in the Venturi pump. We will talk about this in detail in a further slides. So in a peristaltic pump, it pulls the fluid and lens material into the phacotip by compressing tubings over the speed rollers in a peristaltic movement with the peristaltic movements. So faster the rollers rotate, more fluid is withdrawn and more development of aspiration flow rate. So this you can control with the help of your console, that how much you want to increase. So during FACO, whenever we ask our assistant to increase the aspiration flow rate, so sometimes we say 25, 30, 35. So this is that aspiration flow rate. So it directly controls the aspiration flow rate and indirectly controls the vacuum. How? It indirectly I'm saying because it is vacuum is only created when the tip is occluded. Once the tip is occluded, then it will lead to creation of vacuum. So what is AFR? In a single line, it is the volume of fluid removed from the eye in ml per minute. So usually it is set at around 25 to, yeah, 20 to 35 ml per minute. So for higher aspiration flow rate, bottle height is elevated to compensate the to maintain the anterior chamber. So higher the aspiration flow rate, it will lead to nuclear fragments to move quickly to the phacotic, faster the vacuum buildup, and less effective power. So the linear control of and aspiration flow rate is achieved by depressing the foot pedal in the position 2, into the position 2. So, and I have to also told that vacuuming is built only after the tip is occluded. So this is the important term, vacuum rise time. You need to understand. It is a time required to reach the preset vacuum. जितना वैक्यूम हमने सेट किया है तो उतना वैक्यूम रीच करने में कितना टाइम लगेगा आफ्टर द occlusion. So during the occlusion, a higher aspiration flow rate will cause a faster vacuum rise time than the Venturi pumps. So Venturi effect is the Venturi effect क्या होता है कि swift movement of the compressed gas creates a negative suction force inside a closed chamber. So vacuum is created in the cassette, which is act as a closed chamber in this phacoemulsification machine, which is then directly transmitted to the phaco handpiece. So this is the previous diagram. So this is the cylinder through which the gas is passed, compressed gas is passed, and it is directly connected to the closed chamber, which is the cassette. And this cassette is directly attached with the help of with the phaco handpiece from here to here. So as I told you previously, it directly Venturi pump directly controls the vacuum in the aspiration tubing and indirectly controls the aspiration flow rate. So the amount and speed of the gas decides the level of vacuum developed. So vacuum is measured in millimeter Hg, millimeter of mercury. So this is the same diagram. So there is one important point you need to note down is here is change in the vacuum level doesn't always proportionally change in the flow rate because the port size and resistance in the passage also modify the flow rate. So its significance is I have discussed in the Phacotip. That's why there are many types of Phacotip which have been made during the evolution, like the micro Phacotip and flared Phacotip. So advantage क्या है vacuum का? Vacuum is directly transmitted to the tip, ensuring a better flowability. Now, the flow rate. If I'm talking about flow rate, you just need to assume that I'm talking about the peristaltic pump mainly. So it determines the how fast the things will happen in the eye. At a high flow rate, lesser the rise time, sooner the material clear out from the AC. If it is too high, events may occur uncontrollably fast. So fast rotation leads to decreased pinching action and it will lead to slippage of the rollers. So the effective aspiration flow rate is decreased if the rollers rotate too fast. So the optimum flow rate is 25 to 36. Now the vacuum. Vacuum is the holding power. Okay, holding power which is directly proportional to the port size. So vacuum is a double-edged sword and must be used very carefully. Vacuum setting depends on the machine capability. So rise time, I have discussed previously also. It is the time taken to reach the maximum preset vacuum after the occlusion is achieved. So in this diagram, you can see that the vacuum of the Venturi machine rises very sharply, and in a peristaltic, it develops gradually. So in a Venturi pump, uh, rise time is fast and depends upon the highest preset vacuum. And in a peristaltic pump, rise time depends on the flow rate. So this is a video that how to check your vacuum setting, how to check the vacuum. So pinch the aspiration tube, which is seen in my right hand. Okay, you just need to observe here. I'm just putting arrows there, and release the tubing from the right side, from the right hand, and see the movement of the chamber, silicone chamber. So if the test chamber collapse, then post occlusion surge will be there, definitely there. Can you appreciate this? I'll play this video again. If it is collapsing, that means you need to lower down your settings. Decrease the vacuum again. So this is how you can check. Now the basic few terms, followability. So followability is the tendency of the nuclear pieces of the cortex to come into the phacotype. So the positive pressure and negative pressure, which is the positive pressure, suppose this is a phacotype. Positive pressure from the irrigation sleeve. There is a positive pressure and this is the aspiration. So this creates a pressure gradient in this area. So yeah, so this pressure gradient will lead to formation of eddy currents, and this eddy current will lead to the flow of the nuclear pieces into the phaco probe. So area encompassed by these eddy currents are known as the zone of fallibility or the triangle of tranquility. So this is a triangular area, as you can see. Oh, so we have diagram also. So this is the positive pressure and this is the negative pressure, and there is a zone of fallibility which is also called triangle of tranquility. So in this area you have the best fallibility. One more thing, large pieces have poor fallibility and small pieces have tendency to come easily into the eddy current. So before aspiration, the large piece should be broken down into small pieces or the chopping should be done. So fallibility decrease as moved away both horizontally and vertically from the tip. So there are multiple, so the zones of fallibility have been divided into three zones. One is the green zone, which is the central safe zone, and the area of highest fallibility. And one is the yellow zone here. So yellow zone is the angle of the anterior chamber and the capsular fornices. Avoid iris and bring the pieces into the central safe zone before phacoemulsification. So if whenever there is a piece in this yellow zone, you need to bring this piece either manually after putting visco, or go very slowly, very gently. So red zone, which is the area of no fallibility. So it is the area near the यहाँ पे. So it is the area near the incision, main port incision and side port incision. The side port, main port, and dome of the cornea. So fragments here will not come directly into the tip. So you can bring them manually after putting Vesco, or you can lower down the setting, or take out your probe and then aspirate them. So one more term is compliance, which is very important to know because it is the basis of the development of the phaco tubings and prevention of the surge. So it is the property of the silicone tubing to collapse. So in a peristaltic pump, whenever there is no occlusion, rollers are keep on rotating and there is no collapse of tubing. So it is moving. very well. So once the occlusion happens, the vacuum build up and rollers will stop, and it will lead to compression of the tubing. So negative pressure will lead to compression of the tubing. So once the occlusion breaks, so there is a release of negative pressure occurs and tubing re-expands. Means when the occlusion breaks here, so vacuum suddenly decrease and there is a sudden gush of fluid into the aspiration tubing, and it will lead to the collapse of anterior chamber. And this is what is called a surge. So collapse is more at the higher vacuum, less collapse when the lumen is smaller and walls are thicker. So this is the same diagram. So the nuclear piece is here and it is moving smoothly. Fluid is flowing through it. And whenever this piece comes here, it will lead to the collapse of the tubing and development of the vacuum. It will increase the vacuum and rollers will stop. And whenever it breaks, a nuclear pieces, whenever it breaks, it will it will lead to surge. And can you see this posterior chamber is collapsing and posterior capsule is coming upward. So this is why surge happens. So we'll talk about surge. So it is basically a sudden withdrawal of fluid from the anterior chamber after the occlusion breaks. So it leads to collapse of the anterior chamber and jeopardizing the vital structures. So to maintain the IOP and anterior chamber volume, you need to uh, equalize the infusion and the outflow. So for a given bottle height, inflow or infusion and leakage is the constant, and variable parameters include the aspiration flow rate and vacuum, which you can control in most of the machines. Decreasing the aspiration flow rate will increase the rise time and makes the procedure slow. So how do you prevent the surge prevention? So this is just a basic technique you need to note down uh, during your fellowship. So fellows need to note it down. So during chopping or phacoaspiration in a hard cataract. So here you want to maintain the hold. For a hard cataract, you want to hold the nucleus. So and hold is a function of vacuum. So you can increase the vacuum here. So maintain the high vacuum and lower down the flow rate. And for the divide and conquer technique, sculpting or soft cataract or epinuclear plate remover. So here the hold is not so important. So lower down the vacuum and maintain the aspiration flow rate. So surgeon can be controlled by us. Surgeon can control the uh, surge, and machine can also. There are some modifications in the machine is also done, which can control the surge. So first we will talk about the machine controls. So the high vacuum tubing. First is the high vacuum tubing. As I was talking about the compliance. So to prevent the surge, so the thickness of the tubing is increased and diameter is decreased of the tubings. So this will these tubings are called high vacuum tubings. Use of the cassettes to decrease the compliance of the tubing. One important thing is venting. So the machine has a sensor which detects the occlusion break and releases the fluid to fill the volume of the re-expanding tubing. This prevents the fluid being redrawn, being drawn out from the AC. So this is how it works. So whenever the occlusion achieved, so venting valve is there. It will detect whenever the occlusion breaks. So ये diagram गलत है. So this whenever it breaks into multiple pieces, so it will cause rise of the vacuum, and it will release either air or fluid, and surge is prevented, and there is no collapsing of the tubings. So the fluid has come into the tubings. After the occlusion breaks, start of the motor is delayed. This is one more mechanism. After the occlusion breaks, some machine has a sensor in which the motor is stopped after the occlusion break, and it is delayed till the complete expansion of the tubing. And fifth is, after the occlusion break, some machines can switch on to decreased vacuum and aspiration flow rate setting till the occlusion breaks. Once the piece is aspirated, the setting then revert to the previous one. Then the surgeon's control. So, decreasing the effective flow rate, one, using a small bore aspiration microflow tip or the flared tip, and increasing the infusion, raising the bottle height. You can also use anterior chamber maintainer. Proper wound construction is important, as the leaky wounds will lead to anterior chamber collapse. Use of viscoelastics during the last piece, and the foot control. You need to master it. You need to develop good reflexes and good feedbacks, which I have told, that auditory feedback and tactile feedback and visual feedback. So foot control is very, very important. So you need to have a good reflex. So good pattern control will ensure the safe surgery. So I have some MCQs for the fellows. So I will come to know that fellows are listening me very well. These are the basic MCQs, not too difficult. If you are listening me, then you will be able to answer it very well. So unmute yourself and answer it. Any fellow? Am I audible?
Yes, sir. Option C, sir.
Okay. Okay. Nice. Okay. So we have option C. Nice. Second question. It is easy one. Very easy.
C.
Okay. और कोई?
C.
Good. C. False statement.
D.
D.
D, sir. D.
Any other? Good. ठीक है.
B.
Mechanism of
B.
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 Come again. Huh?
B. B.
Okay. The answer is B. So phacoemulsification generates heat wave, not a mechanism. ठीक है?
Yes.
Yes.
B.
vacuum level increase.
B.
ठीक है। सर्ज क्या होता है वो जानना है?
B.
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 B, sir.
B. A venturi pump and also.
B.
C.
ठीक है।
B.
B.
ओके, तो थैंक यू सो मच फॉर लिसनिंग। आई वुड लाइक टू से कि जो भी हमारे फेलोज हैं वो जब कभी भी किसी सीनियर्स का केस कंप्लीट होता है तो वो अपना टेक्टाइल फीडबैक और जो ऑडिटरी फीडबैक है उस पर काम करें अच्छे से, ठीक है। और कभी टाइम मिले फिर उसके बाद आपको जब आप 10 to 15 टाइम्स ये चीज़ कर लेंगे तो उसके बाद आप विजुअल फीडबैक पे भी काम कर सकते हैं। सो दिस इज़ द मोस्ट इम्पोर्टेंट थिंग फ्रॉम माई साइड, and this is my YouTube channel. So what you can do is I have made a separate playlist for the fellows only, in which I have included the only Phaco sounds along with the video. So you can watch it again and again and look for tactile feedback, visual feedback and auditory feedback. You will be able to listen to the voice. So you will know that after occlusion what type of sound create what type of sound is generated, and uh, during the aspiration and during the irrigation also what type of sound is generated. So this is it. Thank you so much. अगर किसी फेलोज को कुछ पूछना है तो पूछ सकते हैं, या फिर किसी को भी।
Sir,
अच्छा डॉक्टर अक्सर, ये क्लास ना एक्चुअली इट वाज वेरी गुड। जो भी आपका प्रैक्टिकल एस्पेक्ट है सब कुछ बताया हुआ है। एक बार आप ये जो उसका पीपीटी है वो ग्रुप में डाल देना, सो दैट पीपल हु कुड नॉट जॉइन दे कैन सी। और ये मैं वीडियो भी डाल दूंगा एकेडमिक सेल में। ठीक है, थैंक यू।
ठीक है, ठीक है। थैंक यू सो मच सर, थैंक यू सो मच। एनी क्वेश्चन?
गुड मॉर्निंग सर।
हाँ जी, गुड मॉर्निंग।
सर ये फेको टिप का जो बेवल है उसका पोजीशनिंग डिफरेंट स्टेप्स में कैसे चेंज होता है मतलब?
ओके ओके ओके। ये चीज़ जो होता है ना, ये सर्जन टू सर्जन वैसे डिपेंड करता है कि व्हाट इज़ द सर्जन्स प्रेफरेंस, ठीक है। बट मेरी तरफ से जो बेसिक टिप है वो ये है कि जो आपका फेको का टिप है, यू कैन पुट इट टुवर्ड द पीस in which direction the piece is there. This is what I prefer or what I do. You will also appreciate in my videos that I use my wrist movements to rotate my phaco tip. In any of the videos I don't have a single position of the tip. So this is how you can do. But on a safer side, you can, if you are a beginner, on a safer side, you can put your bevel edge to the lateral sides, left or right side. This is the most safest way.
ओके ओके
Definitely not toward the for you. Definitely not toward the posterior capsule.
ओके
And one more thing, it also depends कि आप कौन सा step कर रहे हो. During sculpting, you can have a bevel tip toward the cornea also. And during aspiration of the nuclear piece after chopping, you can use that technique which I told you कि जिस साइड पीस होगा उस साइड आप अपना टिप मूव कर सकते हैं।
ओके सर।
आई थिंक हाँ, इतना ही है।
And sir, one thing, like so many tips you had shown, so Like which is the tip which is generally used and works well for almost all the cases?
Okay. So in a common setup, okay, we have most of the time we have the machines like Centurion, Stellaris, Otley, or Opticon. Okay. So we have, for that we have the Kalman tip, which is the bent, and for the Otley machine we have the flare tip.
Hmm.
ठीक है?
Yes.
So you need to master it as per your. So these are the most common tips I have encountered during my experience. So you can use these tips. Both of these have their own advantage.
Thank you, sir.
हाँ जी.
तो आप लोग ये कर सकते हो, आपके हॉस्पिटल में कौन सा टिप है, आप जाके जो टिप खुला नहीं हुआ है उसका एक बार फोटो ले लो और ग्रुप में डाल दो, उससे पता चलेगा कि क्या आप यूज कर रहे हो. ठीक है. ज्यादातर हॉस्पिटल में एक या दो स्पेयर टिप्स रहेंगे, तो उसका आप उसका जो पैकेजिंग है उसको निकाल के उसका कितना साइज है, वो क्या उसका स्पेसिफिकेशन है उसमें लिखा रहेगा. ठीक है, वो एक बार डाल देना. और ये जो एस्पिरेशन बाईपास सिस्टम है वो भी एक बार देख लेना, क्योंकि बहुत सारे फेलोज को देखते नहीं है कि वो है कि नहीं है. वो ऑलमोस्ट अभी जो हम जितने भी ये यूज करते हैं ज्यादातर में रहता है. लेकिन डॉक्टर अक्सर एक्चुअली इट वाज अ वेरी गुड क्लास, वेरी, सब कुछ जो भी ये है बहुत सिंपली सिखाया हुआ है. तो it will be helpful to fellows and also the consultants who have joined.
Thank you. Thank you so much.
So I think we can conclude then. If there are there any other questions or comments? So thank you. Good day.